Good morning, everyone. I'd like to start by first thanking the conference organizers for inviting me to speak at the conference in Vilnius. Unfortunately, I have a competing commitment and I'm here in Querétaro, Mexico for my NIH-funded training program. However, they were kind enough to let me speak with you remotely via a recorded webinar. And what I've been asked to speak on is the issue of defining standards of care and prevention in HIV research, which is a particularly challenging topic and one that I've worked on since about 2006 when I was the science and policy officer for an organization known as PATH, a global health NGO that works on developing new prevention tools to treat diseases that affect the global south, including HIV. And I want to start by reminding you of how difficult an HIV prevention and treatment trial can be because of a number of factors that make them unique relative to other sorts of prevention and treatment trials. And those different criteria are listed here, and they include the fact that HIV prevention and treatment trials often have very complex clinical trial designs, and I'll show you an example of one shortly. But more importantly, both prevention and treatment trials enroll vulnerable populations, including men who have sex with men, commercial sex workers, injection drug users, and minorities. So you're enrolling participants who are largely on the outskirts of society and often are distrustful of researchers and the medical establishment. More importantly, these trials, prevention trials, at least, enroll healthy volunteers. So these are individuals that are at risk of acquiring HIV, but otherwise are not infected. And so that changes, from an ethics perspective, the risk to benefit ratio. You're also dealing with a sensitive, stigmatizing, and often illicit issue. Sometimes, for example, you're working with injection drug users who are engaged in the sale and use of illegal drugs, and researchers might actually become either part of that illicit trade, or they might find themselves in a position where law enforcement officers are staking out their clinics in order to arrest people who are engaged in such illicit behaviors. You also have the fact that results, particularly if you're talking about HIV prevention or treatment that involves user-controlled interventions such as pre-exposure prophylaxis or microbicides. This can be affected by user behavior. And finally, because these trials, at least the phase 2 and phase 3 ones, often enroll a large number of participants, you usually have multiple trial sites and sometimes even transnational collaborations. Now, this is an example of a basic trial design for an HIV prevention study where you have the initial recruitment of participants followed by screening visits and enrollment visits that include HIV testing, testing and treatment for sexually transmitted infections, and pregnancy testing. And then participants are randomized into either an experimental arm or a control arm. And both arms receive a standard package of prevention that includes condoms, counseling, sexually transmitted infection testing and treatment, and other prevention tools. And then the experimental arm gets the experimental product, be it a vaccine, a microbicide, or pre-exposure prophylaxis, while the control arm receives a placebo. And then you look at how many in those groups over a defined period of a year or two remain HIV negative. It's important to note, of course, that anytime you're talking about the use of a placebo in a control arm, it raises a number of ethical issues. Now, placebos are ethical in certain circumstances, and these are listed here. Most ethicists will agree that it's okay to use a placebo in a study in situations in which there's no standard therapy. Standard therapy is no better than the placebo. The standard treatment is placebo. There is doubt about the net therapeutic advantage of standard therapy when the study enrolls participants who are refractory to standard treatment, or when the placebo is added on top of standard treatment, and these are called add-on studies. And most HIV prevention studies are examples of the latter, in that the standard treatment is considered to be this large prevention package, and then you add the experimental intervention, the vaccine, the microbicide, or pre-exposure prophylaxis, on top of the standard prevention package. Now, there are a number of additional ethical questions that come up when we're talking about standard of prevention, but I want to start by first defining what standard of prevention is, and that is the package of prevention strategies and methods that are provided to participants in an HIV prevention trial in order to help them stay uninfected. And these tools are generally provided to participants in both the active and the control arms of the trials. Now, the fact that the current approach is often described as Cadillac prevention and care might be an unfamiliar term to you, since not everyone in a conference in Vilnius may appreciate this American automotive euphemism, but Cadillac obviously refers to the gold standard, or the best of the best. And currently, the best of the best includes intensive HIV and risk reduction counseling, condoms, STI screening and treatment, often at levels that are greater than otherwise available in the community. And thus, the investigator's dilemma is that the more effective this prevention package is, the more difficult it will be to determine whether or not the experimental product works. And I'll show you graphically what I mean by that. So the ethical questions I want to sort of discuss in my my talk here are what is the obligation to provide new HIV prevention tools to participants enrolled in planned or ongoing clinical trials? And is it ever ethical to provide less than the Cadillac standard of prevention to participants in HIV prevention trials? And the latter question is a very important one, in particular because many HIV prevention studies are beginning to experience situations of futility. So, what are some of the scientific challenges associated with providing a Cadillac prevention package? Well, it makes it very difficult to assess the experimental intervention, and this is because of a number of factors. You have social desirability bias. Specifically, you'll find that many of the participants in your study will be using HIV prevention tools that they might not otherwise use in order to appeal to the goals of the study, in order to meet the expectations of the researchers, but that this is not sustainable, that once the trial ends, you'll actually have these participants stop using these interventions. It also can affect your measurement, and it can attenuate your power. Finally, most of these prevention packages actually don't address the needs of many participants, and thus are unsustainable once the trial ends. And I'm going to, in the next few slides, I'm going to go through some examples of what I mean by most of these scientific challenges proposed by a Cadillac prevention package in an HIV prevention trial. And so this is an example of just what you're looking at. So you're trying to evaluate the efficacy or effectiveness of the new intervention, be it a vaccine, a microbicide, or pre-exposure prophylaxis. And the effect of the vaccine in terms of preventing HIV acquisition is shown there in yellow. Now, when you add on an effective prevention, such as condoms over that, it can actually hide the effect versus the control, but you still can at least see the attributable fraction of HIV prevention that's associated with the new vaccine. But what happens as you begin to add in additional interventions, such as PrEP, such as a microbicidal gel, the use of those begins to occlude the attributable fraction, and by the in a study in which the standard prevention package includes a wide variety of known effective intervention tools, such as PrEP, such as condoms, such as an effective microbicidal gel, you reach the point where actually seeing the fraction of HIV prevention that's attributable to the new technology is actually quite difficult. I don't know if you can see it on the screen that you're watching right now, but you can barely see a slight edging of yellow, and that's exactly what the researchers and the statisticians are trying to look for in an entire sea of prevention that is associated with the other parts of the HIV prevention package. And I want to show you what effect that has in terms of sample size and cost of a trial. So this is a very simple trial that assumes a background HIV rate of 4%, so a little under 5 out of 100 participants in the trial should acquire HIV in a given year. And if we assume that the effectiveness of the standard package is 0% and the effectiveness of the new intervention is 55% in a study that has 12 months of follow-up with 100% attrition, and requires 300 HIV endpoints, you would need to enroll a little over 10,000 participants. And when I did these economic calculations when I worked for PATH back in 2009, the estimated cost of that trial was $71 million US. $71 million for a one-year trial. Now, as I've mentioned, we're giving many participants a Cadillac package of HIV prevention, and that Cadillac package of prevention has some measure of effectiveness. So what happens if we put into our sample size and cost calculation an effective package of 55%? Well, without changing any of the other characteristics of the study, we double the number of participants we require to over 20,000, and that doubles the cost of the trial to $142 million US, approximately. Obviously, there are some costs that are not dependent on the number of participants, but are rather associated with things like training staff and developing public health infrastructure, depending on the region of the world you're working in. Now, this all assumes a background rate of 4.5%, which is a very high rate of HIV in a community, but not unheard of. Many of the communities in which I've worked in Eastern and Southern Africa had background HIV rates of 5, 6, or even 7%. But what's interesting is we found that the incidence before and during a trial changes, and this is associated with some of the issues that I've mentioned before, including social desirability bias. Specifically, that during the trial, being in the trial actually causes participants to take less risks. I often like to joke that the easiest way to prevent HIV is actually to enroll everyone in an HIV prevention trial, because it affects their behavior. And this is just an example of two trials in which the pre-trial estimate was much higher than the during trial estimate. And so in one study in Cameroon, it was a 14% HIV incidence rate before the trial was done, but during the trial it was cut in half. Similarly, a study in Nairobi in a community that had a 6% incidence rate, during the trial the incidence rate fell to less than 4%. So what impact does that have on our study design? Well, if we add into our previous assumptions of a effectiveness package of 55% and a new intervention with an effectiveness of the standard package of 50%, and the new intervention is 55%. If the estimated rate of HIV acquisition drops among trial participants to 2%, it actually makes the numbers even greater. So the number of participants that you now need for a single 12-month study is 50,000. And the estimated cost of that trial is over $250 million US. And obviously, anyone who's familiar with the amount of money that funders like the U.S. National Institutes of Health or the Medicines Research Council in the U.K. provide to support HIV prevention trials, you know that this means that these trials are essentially unachievable. Now, I want to also give you an example of the effect that the introduction of new interventions can have on an established trial. And this is a trial. It was known as the VOICE trial, and it was a study of the effect of safety and effectiveness of 1% tenofovir gel, oral tenofovir, and oral Truvada for the prevention of HIV infection among 4,200 at-risk women in sub-Saharan Africa. And the study design, it was actually a complex design, but it was a 5-arm design in which participants were randomized to either receive the oral pill or the vaginal gel, and within each of those arms there was a placebo control arm. So it was a 5-arm study equally divided among oral Truvada, oral tenofovir, an oral placebo, tenofovir gel, or a placebo gel. And what happened was, as this trial was going on, additional studies began to show effectiveness, and researchers began to worry that they could no longer include women in arms of the study that other trials had shown were ineffective or likely to be less effective than the other interventions. And so what happened during the voice trial is in March of 2010, the Caprica study of a tenofovir gel showed that it was almost 40% effective in preventing HIV transmission and acquisition. And so the researchers actually ended the vaginal gel placebo arm and enrolled all of those participants into the tenofovir gel arm. Now, following the other question that came up, of course, was whether or not then, if you know tenofovir gel is effective, do you have to give it to the women who were randomized to the oral pill arm? But the decision was made not to do that. Now, what happened later was the IPREX study showed that oral Truvada could reduce infection risk by 44% among MSMs, and that was in December of 2010. And so they closed out the oral placebo arm and enrolled all of those participants to the Truvada arm. However, this was still a valid study because they were looking at the differential effectiveness of oral Truvada, tenofovir, and tenofovir gel. Yet, what then happens is the FemPrep study of oral Truvada in women was stopped due to futility. So it appeared that oral Truvada was effective in MSMs, particularly MSMs in the United States and in Latin America, but wasn't effective in women in sub-Saharan Africa. So the decision was made to stop women who were taking Truvada and enroll them in the tenofovir arm. And then finally, the Partners in PrEP study showed that oral Truvada and tenofovir was effective among women in sub-Saharan Africa. So again, the researchers then reopened the Truvada arm. But then the question became, well, then do we have to, because the Partners in PrEP study showed that oral tenofovir was less effective, do you actually then have to take the women who were in the tenofovir arm and put them into the Truvada arm? So essentially what ended up happening is all of these changes greatly attenuated the power of the voice trial, and the voice trial itself was stopped due to futility. Now, when the researchers in the voice trial made the decision to provide things like tenofovir or the tenofovir gel to some of the participants, they were making that on the decision that it had been proved effective in another study, and thus it was unethical not to provide it to participants in other arms of the study. And so what they were contemplating is, when does it become required for you to say, take a tenofovir gel that was proven effective in the Caprica 004 study and provide it to all participants in the study as part of the standard prevention package. And a lot of what we talk about when we say that a researcher has to provide a state-of-the-art intervention to study participants, we talk about only providing those interventions that are both established and proven. And in order to do that, we have to define what we mean by when something is proven to be effective. Is it one trial? Is it two trials? Is it a trial in a similar population or a similar region of the world? And more importantly, even when something is proven effective, we have to talk about what we mean when it becomes established, because there are many interventions that we believe are effective that are not established, either because the medical community or the regulatory authorities have not yet approved it or added it to the standard prevention package in that country, or sometimes something has become established without becoming proven. And in order for something to become proven, really it has to meet certain levels of evidence. And this is just a graphic showing you the evidence pyramid of when something is known to be effective, and the level of the increasing strength of the different levels of evidence, ranging from expert opinion up through in vitro research and case studies and case reports, all the way up to randomized clinical trials, and then finally systematic reviews and meta-analyses. And the randomized clinical trials and the systematic reviews and meta-analyses are usually what we expect to see when we want to say that something is proven to be effective. However, when we look at prevention strategies that we use in HIV prevention, and these are shown here depending on their actual point of effectiveness. It's interesting to note that many of the things that we include in the standard prevention package, the Cadillac prevention package, actually aren't proven. And I want to show that to you here. So there's a lot of things that people provide to participants as part of a standard prevention package that actually haven't been proven or have only been partially proven to be effective. And some of the ones that I'd like to highlight are the fact that we tend to screen all participants in an HIV prevention trial for herpes simplex 2 on the basis of research that shows that co-infection with herpes simplex or infection with herpes simplex 2 increases a person's risk of acquiring HIV. But every study done to date, every large study done to date, looking at herpes simplex virus 2 screening and treatment in order to prevent HIV infection has actually proven to be flat. So there's no study that has shown that if you screen at-risk individuals for herpes simplex 2 and then treat that condition, that you actually reduce their risk of acquiring HIV infection. And no one understands why that is the case, yet we still include that in the HIV prevention package. Similarly, and this was surprising to most, there's never been a well-controlled study of things like male or female condoms or pre-exposure prophylaxis to show that those are effective, yet we do provide them. And so my point here is simply that it requires careful consideration of the impact of including a new strategy in the prevention package for a planned or an ongoing trial. And if we are relying on the weight of evidence, then the challenge becomes exactly what level of evidence do we need? And if we conversely, if we require a randomized controlled trial or even a meta-analysis, then many of the things that we already provide actually we could remove from the prevention package. Similarly, we have to talk about what it means when an intervention becomes established. And I already alluded to this, but some of the examples of when something becomes established are it's recommended from a normative agency, it's added to the national prevention strategy, or becomes common practice. An example of when this affected ongoing clinical trials was when the research began to show that adult male circumcision, at least in regions of the world where circumcision was uncommon, actually reduced the likelihood of acquisition of HIV by an uninfected adult male. And that was on the basis of 3 very strong studies that were done in Eastern and Southern Africa. Now, what's interesting is on the basis of a single circumcision study, researchers who were doing an HIV vaccine trial in South Africa made the decision to offer male circumcision to all participants in that trial free of charge. Now, that was done despite the fact that male circumcision hadn't been yet recommended as an HIV prevention tool from a normative agency like UNAIDS or the World Health Organization. In fact, that recommendation didn't come down for an additional 9 months, yet the researchers decided solely on the basis of its proven effectiveness that it was absolutely essential to provide that to all participants in that study. Similarly, if you want to talk about national prevention strategies, that would mean that in any study going on in a country like Kenya, for example, you would not be required to provide pre-exposure prophylaxis as part of the standard prevention package because that is not yet approved for use in that country as an HIV preventative, despite the fact that it's approved for use in countries like the United States, and it has not been added to their national prevention strategy. So what can we do? Well, we can look at current guidance and the guidance from normative agencies that currently exist. The strongest out there is this guidance from the UNAIDS World Health Organization in 2007 on ethical considerations in biomedical HIV prevention trials. And that document, Guidance Point 13, states that researchers, staff, and sponsors should ensure that appropriate counseling and access to all state-of-the-art HIV risk reduction methods are provided to participants, and that new HIV risk reduction methods be added based on consultation among research stakeholders, including the community, as they are scientifically validated or as they are approved by relevant authorities. And again, this is the guidance, but it doesn't really address any of the problems I've already talked about. More importantly, it's interesting that this guidance recommends that they be added to the prevention package as they are scientifically validated or as they are approved by the relevant authorities. That or rather than an and is very important, because there are many scientifically valid interventions such as circumcision, such as pre-exposure prophylaxis, that aren't necessarily approved by relevant authorities. Conversely, there are many things that haven't been scientifically validated. As I mentioned, herpes simplex 2 treatment and that has been approved by relevant authorities but has never been scientifically validated. Now, this was the most comprehensive guidance, but what we decided to do based on the lack of clarity in this guidance and a lot of confusion among the researchers and the trial sponsors about when it would be appropriate to add a new prevention tool into a prevention package of a planned or an ongoing trial, we at PATH decided to host, in collaboration with UNAIDS and the United States Centers for Disease Control and Prevention, a consultation that brought together 59 diverse participants, researchers, community members, HIV advocates, and policymakers. We brought them together for a 5-day consultation in Kampala, Uganda, to review the scientific, ethical, and community issues that were relevant to deciding when prevention services should be offered in HIV prevention trials, to identify criteria or processes to aid in future decision making, and to develop a document outlining the areas of agreement and disagreement in this case. And a detailed meeting report is available through the website of one of PATH's subsidiary organizations, the Global Campaign for Microbicides. And the summary report was actually published in the Journal of Medical Ethics back in 2011. And what that consultation for that consultation, we started with the UNAIDS guidance, but then we asked them to explore exactly what that guidance meant, and to come up with a set of criteria during which new prevention trials could be added to the current standard package of prevention and care offered to research participants. And what the participants concluded was that all trial participants should be ensured access at no additional cost to them to new HIV prevention tools if an international normative body or a national policy-making process recommended the use of that new method or strategy for the population group that was enrolled in the ongoing trial. The participants also concluded that all trial participants should be offered that tool, but the obligation to provide it by researchers and by sponsors was less clear in the absence of a clear international policy on this. And it was felt in those situations the decision should be made on a case-by-case basis using a local consultative process and guided by several criteria. And those criteria are listed here, but include data from comparable populations and routes of exposure, weight of evidence for estimates of effect or effectiveness, the feasibility and the impact on of the tool on the ability to isolate the efficacy of other prevention methods being tested for ongoing trials. Now, there were some other criteria that were brought up, including safety concerns, expert review, and feasibility, but I don't want to really explore those here. Now, that said, I do think that in light of a lot of recent research, there are concerns about whether or not HIV prevention research in particular has reached a threshold of futility, and whether or not we need to reconsider the level of prevention that we offer as part of the standard prevention package. And in thinking about this, I immediately obviously was brought back to the ethical principle of beneficence. So many of you in the audience are probably familiar with various bioethical principles and frameworks. I tend to rely on the Belmont principles, which are in many ways considered to be the holy trinity of research ethics principles. And those principles are respect for persons, or obtaining voluntary informed consent and ensuring that vulnerable populations are protected; beneficence, which is the principle of do no harm to maximize benefits and minimize risks of study participation; and then finally justice, or non-exploitation. And it's this rule of beneficence, as mentioned in the Belmont report, that many people suggest implies that HIV prevention researchers have an obligation to make sure that all participants in research studies actually have access to a wide range of HIV prevention tools. But what's interesting is I actually think that providing those tools is not done to minimize potential harms. Rather, it's done to maximize potential benefits. And part of the confusion comes from the fact that the different ways in which ethicists and HIV researchers use this term risk. Researchers look at HIV prevention tools as risk reduction methods. However, when research ethicists such as myself speak of risk, we're talking about the risks directly associated with trial participation. For a vaccine trial, those risks might include an adverse physical reaction to the immunogen or adjuvant, or perhaps psychosocial harms and stigmatization associated with trial participation. However, we don't consider HIV acquisition to be a risk of trial participation. Individuals who seroconvert while enrolled in a prevention trial become HIV infected despite their participation, not because of it. Now, this is not an absolute. There are many situations in which the experimental product under investigation might actually increase the risk of infection, as was the case with the frequent use of Naloxone 9 in early trials of that product. However, the way to address that issue is not by providing additional HIV prevention tools, but rather through extensive preclinical and phase 1 safety testing. So I would argue that when we talk about the obligation of researchers to provide new HIV prevention tools to study participants, we're talking about the obligation to maximize possible benefits, not minimize potential harms. But this obligation to maximize benefits is not limitless. If you use that limitless principle, you could easily argue that researchers conducting HIV prevention research in resource-poor regions of the world also have an obligation to provide antiretroviral treatment to participants who seroconvert, or to provide health care for conditions like malaria or tuberculosis, because those interventions would also provide a direct benefit to trial participants. Now, while it's morally praiseworthy to provide such services, we actually don't have an obligation to do so. And so I would argue that a more rational approach is this. I would argue that as new HIV prevention interventions become available, all trial participants should have information about these proven and established HIV prevention services, but that it's not ethically obligatory to always provide or ensure access to the full range of proven and established prevention tools. In fact, there are many prevention tools that individual participants or the communities might not want to use, either because of risks or because of social considerations. So instead, I think it's acceptable to allow the prevention trial package in a trial to vary in the type of services being provided, so long as it's developed in consultation with the community and addresses the specific needs of the community. And this might even mean that the prevention package that's offered in one community of a multi-site trial may be different from the prevention package that's offered to members of a different community. And while that is a fairly novel and controversial position, I don't think that it's necessarily one that is ethically unjustifiable. And so with that, I just want to finish, and I want to thank you for your time. And if anyone has any questions, please feel free to email them to me. The conference organizers can provide you my email address. Thank you so much, and goodbye.